So Prashant and I would like to welcome you to the first in-person cardiology grand rounds for the year. And we'd like to thank Arthi for her help in planning the grand round series for many, many years and for the thorough transition to us. And I'd also like to introduce Gabby, who took over from Eva as the cardiology grand rounds administrator. Thank you, Gabby, for all your organization and for the excitement for this morning with the computer not working. We got it running. So it's my pleasure to introduce our esteemed speaker for today. Dr. Ardehali is joining us from the University of Arizona. He obtained his MD and PhD degrees from Vanderbilt University and completed his internal medicine and cardiology training at the Johns Hopkins Hospital. He then joined the faculty at Northwestern, where he had appointments in both the Departments of Medicine and Department of Pharmacology. At Northwestern, he was the director of the Center for Molecular Cardiology, the Thomas D. Spies Professor, and the director of the Medical Scientist Training Program. Dr. Ardehali joined the University of Arizona earlier this year, and he is the Irving J. Levinson Professor of Cardiology, the Associate Dean for Translational Research and Training, and the Director of the Medical Sciences Training Program, as well as the Associate Director of the Sarver Heart Center. His research has elucidated the role of iron and iron regulation in normal cardiovascular physiology and the mechanisms by which perturbations in iron metabolism can contribute to cardiovascular disease, with direct impact on the management of heart failure, coronary artery disease, and chemotherapy-related cardiotoxicity. He's a former president of the American Society for Clinical Investigation and is a dedicated mentor to many. Dr. Ardehali, thank you so much for joining us today.
All right, thank you. Thanks for having me. Beautiful room, beautiful view, and sorry for the delay. So today I'm going to talk to you about a topic you have probably not heard of, which is the role of iron in cardiovascular disease. And I think there is a lot to learn here. And I want to go over some of this topic in detail. So basically, this is a slide I want to give credit to my friend Joe Hill, who gave me this slide. There is a big gap between basic science and clinical science in a lot of different areas of cardiovascular research, as you know. But I don't think this gap exists more than what we see in iron in cardiovascular disease. And that's basically what I've been trying to do as a physician scientist, to bridge this gap between clinicians and basic scientists. So why do we care about iron? Iron is becoming a multi-billion-dollar industry. For those of you who have been on the heart failure service, you know a lot of patients who come in with heart failure, they get IV iron. And that has been an area that has been growing, and there is a lot of investment into, or a lot of expense that goes into that area. What do our cells use iron for? This is basically a list, and I'm going to come back to this. Most of the iron that is used is in the mitochondria. In fact, if you take mitochondria out of the cells can survive. As you know, they can make ATP, they can do a lot of things. The only function of mitochondria that the cells need for is iron homeostasis. That's one function as eukaryotes. We still haven't learned not to get it out of the mitochondria. We still need mitochondria for iron homeostasis. And, it's really fascinating how iron is used for iron sulfur cluster synthesis and heme synthesis in the mitochondria. So as I showed in the previous slide, iron is needed for a lot of different cellular processes, but iron is also bad if it is too much of it. And why is it bad? It's because iron is a source of reactive oxygen species. Many of you know about the Fenton reaction, which is basically we make a lot of superoxide anion, and then we have superoxide dismutase that converts that to hydrogen peroxide. And hydrogen peroxide can be converted to water, or it can be converted to hydroxyl radicals, which are extremely toxic molecules. And what is needed for this conversion of I don't know if this, unfortunately, this doesn't work, but the conversion of hydrogen peroxide to hydroxyl radicals, is iron. So iron levels have to be tightly regulated. Too much is bad for you, too little is also bad for you. Now, I want to give you some examples of how iron is really critical for our biology. As you know, we have a very sophisticated immune system in our body, right? But we have learned to use iron to fight bacteria. We withhold iron. I'm sure you have heard of anemia of chronic disease. You have heard of, low iron in the setting of infection. That's the system we have in our body to make sure that bacteria don't use that iron to replicate. So that's a very sophisticated immune system we have. There is this, just to give you an example, there are two tribes in Africa. One of them has more iron in their beer compared to the other tribe, and they have more risk of amoebic infection because of that increase in their iron levels. Nomadic Somali nomads, WHO decided to give them iron because there were a lot of women who had children who were born with neurological disorders. So they gave iron pills to a lot of these nomads, which was a good thing. But then they realized that there was a significant infection in patients who received iron versus those who didn't receive iron. So this is, again, a system we use in our body to fight infection. And this is how it works. We release this hormone called hepcidin, and the people who discovered hepcidin, they will probably eventually get the Nobel Prize. But what happens is that hepcidin goes and it inhibits iron absorption in the digestive tract. It also inhibits iron release from the macrophages. So overall, the total storage of iron in our body is not reduced. We have the same amount of iron, but the release of iron, the available iron is reduced. So that's why we have functional iron deficiency. This is called functional iron deficiency versus absolute iron deficiency, and I'll talk about that later. So medicinal bleach was used for many, many centuries, and it was working for, and that's what people think why it was working, because it causes bleeding and iron levels go down, and infection, which was a major problem, several, centuries ago. That's how probably medicinal bleach worked in those patients, by reducing iron levels. So there was some probably, some science behind that treatment. Just to give you some other examples of how iron is important, as you know, the yolk is very high in iron, is very high in nutrients. But one thing that has been really fascinating to scientists is that eggs don't really get infected. And the reason, if you have eggs, and the reason is because there is a high levels of this protein in the egg white that binds to iron. So bacteria have to go through this layer to get to the yolk to use the iron, and that's the system that eggs have to fight infection, and they don't get infected as much as meat does, which is a huge source of iron. And then again, breast milk is very high in this protein that binds to iron, chelates iron, but cow milk is very low. And that's another, of course, breast milk also has IgA, but that's another system that has been developed to make sure that it fights infection in children. And many of you probably know about this, thalassemia and sickle cell disease. The map in Africa correlates with malarial infection. So as you know, malaria needs iron to grow, to replicate. But in addition to that, malaria also needs, there is another way of fighting infection, another way that we have learned to fight malaria is by changing the shape of red blood cells. But in addition to that, by withholding iron through, when patients have thalassemia or sickle cell disease, that's another way of fighting malaria infection. So that has, again, what nature has developed to find a way to fight this really deadly infection in Africa. Now, this is a slide I'm going to show you again. This is the history of the Earth. 4.5 billion years ago, the Earth came along, and surprisingly, very soon after that, the first forms of life came to Earth. So about 4 billion years ago. For 2 billion years, and the first thing that people think that happened for life to come to the Earth was electron donation and acceptance. That was the first thing, because you need metabolism is the basic of life. That was the first thing that people think that happened. So for that, primitive organisms use iron and sulfur, right? There was no oxygen. But 2 billion years ago, something happened, and that was the oxygen crisis. And that was because of photosynthesis of organisms in the oceans. And oxygen got released into the environment. And as a result of that, iron became oxidized. Now, as we have developed, we have learned how to use oxidized iron. But the form of iron that we know how to use, or the primitive organisms knew how to use, was reduced iron. So for 2 billion years, we have learned how to deal with iron deficiency. Iron deficiency is a common disorder that not just us humans have faced. We have been, organisms have been facing for 2 billion years. We have learned a very sophisticated system how to deal with iron deficiency. We don't have a system in our body to get rid of extra iron. There is really no system because iron deficiency has been such a major problem that we don't have a system. The only way to get rid of your extra iron is phlebotomy and GI bleed. There is really nothing in our body to get rid of extra iron. And that's, again, because iron deficiency has been a huge problem throughout evolution. I'm going to come back to this because this slide actually formed one of the major projects in my lab. And all of this the credit goes to a really bright MD PhD student in the lab who came up with this idea of iron sensing. And I'll come back to that later. But despite the fact that iron deficiency has been, something that we know how to deal with, the guidelines, especially the European guidelines, are very aggressive in terms of giving IV iron to our patients. So these guidelines came, they were updated 2 years ago, but they gave it a class 2A indication. And it basically says IV ferrous carboxymaltose. So specifically, they said ferrous carboxymaltose. And the people who were in the guideline committee, if you look at their disclosure, almost all of them had connections with the company, which is Vifor. And so this was very surprising that they specifically put ferrous carboxymaltose in the guidelines. American guidelines are more conservative. They gave it a class 2B indication. And then 2 years ago, the guidelines changed and they gave it a class 1. This is European guidelines. And they were saying intravenous iron supplementation is recommended in symptomatic patients with HFrEF or middle range ejection fraction and iron deficiency to alleviate heart failure symptoms and improve quality of life. This was this came out at the ESC in Amsterdam 2 years ago. And at the same time, another study came out that basically refutes this guideline. And that was a study I'm going to show you later. So over the past few years, we have been trying to publish a number of papers. Again, most of my research is in basic science, but a lot of journals, and these are almost all of them were by invitation, even journals like Annals of Internal Medicine, they have invited us to write on this topic. And we have been saying we should be more cautious with our treatment of patients with heart failure because we don't have enough data. And there is evidence that this IV iron, which is extremely expensive, it may have side effects. And also there is no evidence that oral iron doesn't work in these patients, which is something that is much cheaper. You can get oral iron. These are, it's pennies. You can get it from Walgreens and it's not very, very expensive. So the first question that we need to answer is what iron deficiency is. And this is something I alluded to earlier. Absolute iron deficiency happens a lot in young women. There are young women in this room, and it happens. We lose iron, and we have low iron levels. That is, total body iron is reduced. But functional iron deficiency is another issue that we have in our body. If you have low potassium, it's very easy to measure low potassium. But iron is different, is because of this functional iron deficiency, which is basically the total iron in the body is not changed, but the available iron is reduced because we withhold iron in macrophages. We don't release it into the bloodstream to make sure that if there is a bacterial infection, the bacteria don't use that. The same thing is actually true for cancer also. Cancer cells are very dependent on iron, and they find a way to fight, and get iron in their environment. Bacteria do the same thing. There is a fight that goes on between our body and cancer cells, and also bacteria. So this has been a process that has been going on for many, many years throughout evolution, and that has been, has led to this idea of functional iron deficiency. Now, the hormone that is responsible for this functional iron deficiency is hepcidin, as I showed you earlier. And hepcidin is usually increased in the setting of, inflammatory conditions, In fact, that's how it was discovered. It was discovered to be increased in infection, and then later on, Tom Gans at UCLA showed that it's actually the hormone responsible for iron homeostasis. But in heart failure, it's actually reduced. This is a paper we published with Piotr Panikowski. Of course, the bar graphs are very high, but as you can see, as the heart failure gets worse, hepcidin levels actually goes down. So hepcidin is not increased like what you see in rheumatoid arthritis and in its, chronic inflammatory conditions. It's actually reduced in heart failure. So what are the diagnostic criteria for iron deficiency? These are the heart failure guidelines. They say serum ferritin levels less than 100 and ferritin levels between 100 to 300 and TSAT of less than 20. I bet you all of us in this room have ferritin less than 300. Probably our ferritin is less than 100 too, unless you have an infection, then your ferritin is elevated. So these are very loose criteria. And where did they come from? They actually come from patients with, or guidelines from chronic kidney disease, which makes sense. In patients with chronic kidney disease, they have difficulty producing erythropoietin, so they have to have more liberal guidelines or criteria for iron deficiency. So this cutoff of 100 is in heart failure is arbitrary, and it's not really based on science. And this is an area a lot of people in heart failure field are trying to see what's a better criteria they can use for the diagnosis of iron deficiency. So I just want to emphasize, unlike, potassium, if your potassium is 3.2, you're going to get Torsade, so you got to replace. We are taking our boards tomorrow in the EP, so that's why I know. So, so you replete potassium because your potassium is low. That's not the same thing with iron. If your ferritin is high, it doesn't mean that you have iron deficiency if it is less than 100. You can still be iron replete. So a lot of people who are given iron in clinical trials or on the floor are not truly iron deficient. And that's because these criteria are very liberal. I'm not going to go over this, but there is a lot of epidemiological studies that low iron is actually good for you for cardiovascular disease. So and these are epidemiological studies. Of course, they don't establish cause and effect, but they show that it is associated with reduced cardiovascular disease. And this is actually true. Blood donors have reduced cardiovascular disease if you correct for everything else. I'm actually a very avid blood donor. I haven't given blood since I moved to Arizona, but you can give blood every 3 months. And my ferritin went down to 11, which is very low. And I was getting restless leg syndrome. So that's one of the side effects because there is not enough iron in the brain, and that causes restless leg syndrome. And I still get some of that, but my ferritin was 11. I was truly iron deficient. When your ferritin gets that low, you're truly iron deficient. But again, this is a good practice. If you're not giving blood, I really encourage you to give blood. And in addition to that, you can get this, junk food that my wife would never allow in the house. So that's, yeah. So there are 7 or 8 studies that have been done in the field of iron in cardiovascular disease. The first 3 were smaller studies. And these are the 3 studies. And basically, they showed that there is improvement in symptoms. One of the studies, I want to just tell you how much push there was for this idea that IV iron is beneficial. Affect Heart Failure showed that peak VO2 is improved in patients who receive IV iron. But there were 3 or 4 patients in the placebo arm who died, and they were assigned a value of 0 for their peak VO2. That's how they saw a difference between the 2 groups. I don't know how this paper got published, but that's if you take those 3-4 patients out of the groups, there was no difference between in the 2 groups in peak VO2. So these are the 3-4 studies that I'm going to discuss. Affirm AHF, again, it did not meet its primary endpoint. Reduction in heart failure hospitalization in IV iron group was noted in sub-analysis, but there was really no effect on the primary endpoint. Iron Man was another study. This was not with ferrous carboxymaltose. So this was one of the only studies that wasn't with ferrous carboxymaltose, and it wasn't sponsored by Vifor. Everything else was sponsored by Vifor. What they saw also was that there was no IV iron was not superior to usual care in primary endpoint. So it didn't meet its primary endpoint either. And then this was published at the same time, or this was presented at the same time in Amsterdam as the guidelines were changed. So this is a heart fit study. I don't think you can see two curves being more superimposed than you're seeing here. So there was, again, it didn't meet its primary endpoint. So all of these studies, none of them have met their primary endpoint. There was a paper that was just published in Nature Medicine. I actually reviewed that paper. There were a lot of problems with it, but it argues that if you do meta-analysis, there is a signal of improved outcome in patients. But that was a meta-analysis of all of these studies. So what are the FDA what is the FDA label for IV iron? It basically says that you give it to patients who are intolerant of oral iron or they have unsatisfactory response to oral iron. So basically the FDA encourages you to give oral iron first, unless your patients have chronic kidney disease. So every time we are giving IV iron to our patients, it's off-label, off FDA label. This was, the label may be changed, but that's basically the label, FDA label. And then how about oral iron? I talked about oral iron. So oral iron is a way, it's actually a system we have in our body to make sure we absorb iron if you're truly iron deficient. So this is how it works. When you have sufficient iron stores, then the liver produces hepcidin. And hepcidin goes and binds to the ferroportin, and it reduces iron absorption in the digestive tract, and also reduces iron release from macrophages. So this is how it works when we have enough iron. When you have iron deficiency and when there is not, inflammation, hepcidin doesn't get released. So you are going to absorb iron. If you're iron deficient, you will absorb iron. And that's basically that happens in patients, if you're truly iron deficient. So as I said earlier, a lot of these patients who are in clinical studies, they are not really iron deficient, so they're not going to absorb iron. So people who are in the field of iron, they refer to this clinical trial called Iron Out HF, and they argue that oral iron doesn't work. So oral iron out compared the placebo versus oral iron, and they saw that peak VO2 wasn't changed between oral iron and placebo. But as you remember, I also mentioned that IV iron doesn't work either in increasing peak VO2. And if you look at the patients who had low hepcidin, and these are truly iron deficient patients, so they did a sub-analysis, they saw an increase in their iron indices. So it's not like, if you put a group of patients, some of them iron deficient, some of them not iron deficient, you give them oral iron, of course, those who are not truly iron deficient are not going to absorb iron, which was the problem with this IV iron. Oral iron, I don't know if anybody in this room has taken oral iron. It can cause digestive tract problems. I took a form of iron and it gave me a really bad indigestion. But I switched to another form and I tolerated it well. And now there are these forms of oral iron that are much better tolerated. And there is a study going on right now, IVO heart failure, that is comparing, for the first time, is comparing oral iron versus IV iron. Every study that has been done was IV iron versus placebo, which, the drug companies would never, IV iron companies would never allow IV iron to go up against oral iron, because if it doesn't show benefit, it's, oral iron is cheap. So this is the first time that there is oral iron is going up against IV iron. So side effects of IV iron, and this is something we have been arguing, infection, cancer, you're basically providing nourishment to cancer cells by giving patients IV iron. And this thing is real, osteomalacia. Patients, especially with ferrous carboxyl maltose. And this is through FGF23 increase in the body. And how iron increases FGF23, we don't know. There is a system in our body, iron talks to phosphate, and we know about that. Nobody knows how. So iron and phosphate levels change, and they talk to each other. And we go to these bio-iron conferences, and people are doing a lot of research in this area, but still we don't know how iron and phosphate communicate in terms of their levels. This paper was published a few years ago, and they looked at all the patients who have received IV iron, and there was a significant increase in the risk of infection in patients who are getting IV iron, which makes sense, right? You're providing nourishment to bacteria by giving IV iron. Right now, we are trying to do a study with these guys at Lundquist in UCLA, trying to look at the effects of oral iron chelators on atherosclerosis. Matt Budoff is an excellent CT angiogram, coronary angiogram, and he can look at the size of the plaque based on CT, and also the unstable versus stable portion of the plaque. Unfortunately, we haven't been able to get funding for it, but we are trying. All right, so that was basically an overview of iron in cardiovascular disease. For the rest of the talk, I'm just going to try to give you an overview of what we have done in our lab. And I've tried to make it as, not too, basic science. And I'm going to show you a couple of Western blot gels. I apologize, but that's basically, I'm going to mostly focus on what we know about how our cells regulate iron. We have published a number of papers in our lab focusing on how iron affects cardiovascular disease. And again, our data suggests that if you reduce iron in the heart, it's actually beneficial. We have shown that in patients with heart failure, their iron levels are not actually increased or decreased. It's pretty much, it's not that much different from normal people. So over the past few years, we have looked at mitochondrial iron, we have looked at cellular iron, and most of the work we have recently been doing on cellular iron sensing. And this is an area I'm going to discuss in more detail. I'm just going to give you an overview of these two areas, and then I'm going to focus on cellular iron sensing. So what we have shown, this is basically how I started my lab. I was very interested in this protein called ABCB8, and that's what I worked on when I was a cardiology fellow in Eduardo Marban's lab. And he was very interested in this protein as being the mitochondrial ATP-sensitive potassium channel. But and that was my project, and after working on this for a while, I went to him and I said, this protein probably has something to do with iron. And he said, well, if it has something to do with iron, I don't want it. You can work on it if you want in your lab. And at that time, I was going to Northwestern, so I made the mouse as soon as I went to Northwestern. And we showed that, if you knock it out, iron accumulates in the mitochondria and it leads to cardiomyopathy. So that shows you that iron, which is a source of reactive oxygen species, can be really detrimental if the levels go up in the heart. I mean, basically, the idea was that ABCB8 is involved in iron export out of the mitochondria. So if you knock it out, iron accumulates in the mitochondria, and that leads to reactive oxygen species, which is a source of oxidative damage to the cell. We also showed that this protein is needed for the maturation of iron-sulfur clusters in the cytoplasm, and nobody knows how we make iron-sulfur clusters in the cytoplasm. There is an idea that some factor is made in the mitochondria that goes to the cytoplasm and is needed for iron-sulfur cluster synthesis. But we are in the year 2025. We still don't know much about how iron-sulfur cluster is synthesized, which is really, really interesting. And then over the following years, we looked at whether or not if we reduce mitochondrial iron, if it is protective. We looked at ischemia reperfusion injury and doxorubicin-induced cardiomyopathy. And we basically, showed that if you have a mouse and you treat them with doxorubicin or treat them with ischemia reperfusion, you get cardiomyopathy. So this, everybody does that in their lab. But if you reduce mitochondrial iron, either by using iron chelators that can get into the mitochondria or by overexpressing this protein ABCB8, which is involved in iron export, you protect against doxorubicin damage and you protect against ischemia reperfusion. So that again tells you that mitochondrial iron levels are really critical for normal function of the heart, and it's very important. So around this time, MD PhD student Marina Baeva joined the lab, and she wanted to study how iron is regulated. And as you know, we know that IRPs are, that's basically we learned that in biochemistry 101 that IRPs, iron regulatory proteins, are involved in cellular response to low iron. Okay, but what IRPs do is that they go and increase the levels of transferrin receptor. They bring more iron into the cell. But that doesn't make sense. If you keep doing that, if you're iron deficient, you're going to deplete iron or take iron away from vital organs like the heart and the brain. You can't just keep using the iron in your skeletal muscle. You need to provide that iron to your vital organs. So what Marina was saying is that there must be a system in our body to preserve iron, to conserve iron. So he called the IRP system iron acquisition system, and he called this system that I'm going to tell you about iron conservation system. So that's both of them exist in our cells. And the protein she focused on is called tris tetraproline, or TTP. And this protein has 3 regions of 4 prolines. So that's why it's called tris tetraproline. That's where the name comes from. And what it does is that this protein binds to AU-rich regions of mRNA molecules, and it causes degradation of the mRNA molecules. So if you degrade the mRNA, you don't make the protein. So that's how it regulates protein expression. So it binds to a number of different proteins. So Perry Blackshear, who discovered this protein, Perry is an endocrinologist. And he was actually here, but then he moved to Research Triangle in North Carolina. He made a knockout of this protein. He was initially looking for proteins that are increased in response to insulin because he's an endocrinologist. He identified this protein and then he knocked it out. And to his surprise, mice with the knockout, they have systemic inflammation. They have dermatitis, they have arthritis, conjunctivitis. And the reason is that one of the targets of TTP is TNF alpha. So when you knock it out, TNF alpha goes up, right? And TNF alpha goes up because it causes degradation of TNF alpha mRNA. So when you remove it, TNF alpha mRNA goes up, the protein goes up. And that's why mice get systemic inflammation. So after these papers were published, almost every paper on TTP was in the field of immune cells and immunology. But what Marina discovered, and again, this was her idea, it was on the cover of Cell Metabolism, she showed that there is another system in the body to conserve iron. And this is what she discovered, was that in low iron, mTOR gets inhibited. And as a result of that, TTP gets inhibited. So this is a double negative. So low iron actually activates TTP. And what TTP does is that it goes and puts a brake on the system so you don't keep bringing more iron into the cell. You need to have that iron available for your brain. If you don't get iron to your brain, you're gonna, it's gonna be worse than the restless leg syndrome I got. It's gonna really affect. In fact, there are probably 3 diseases associated with iron deficiency. One is anemia, right? The second one is women who are pregnant and they're iron deficient, their children, the infants would have neurological disorders. And the third one would be, of course, would be restless leg syndrome. There are really no other diseases associated with iron deficiency. And that shows you how much we have learned how to deal with iron deficiency, conserve iron in our body to make sure that iron gets into the brain. People who are severely iron deficient, I'm sure you have heard of this condition called pica. They go and eat clay because clay has iron in it. And they can sense that where iron is in the environment, which is really fascinating. How they can tell that clay has iron in it is really fascinating. But anyway, so what happens, so in this case, again, this system is developed to make iron available for the brain and for the heart. And then what happens is that another function of this TTP is to conserve iron inside the cell. And I'm not going to get into details of how it is done. Now, let me just switch gears here and talk about iron sensing. And that's the work that Jason Shapiro, another MD PhD student in the lab, started working on. So when I was a graduate student, there was a big interest in systemic nutrient sensing, right? So for example, oxygen sensing at the systemic level is by erythropoietin, right? So we learned that in 1980s, 1990s. We learned about carbohydrate sensing, insulin, glucagon at the systemic level, when glucose changes in our body. Nitrogen sensing is through, different systems. But over the past few years, we have also tried to learn about cellular nutrient sensing. Oxygen sensing, we know at the cellular level, we sense iron in the oxygen in the environment, and that led to the Nobel Prize across the street to Bill Kaelin, who discovered HIF. And then carbohydrate sensing, we learned about AMP kinases. A lot of different proteins are involved in oxygen sensing. Nitrogen sensing, by nitrogen, I basically mean amino acid sensing. mTOR, and mTOR And for those of you who know about it, mTOR then was mostly discovered here in Boston by the function was by David Sabatini, and it basically know that mTOR is the master regulator of analysis. mTOR, when mTOR is activated, cells grow. When it is not activated, cells do not grow. So this is the master hub of cellular anabolism. And this is how it works. So cell growth is through mTOR, and it responds to growth factor, it responds to oxygen, energy, amino acids, but how it responds to iron to regulate anabolism is not known. And this is the work that was done mostly by Jason Shapiro, who is now a resident at Stanford, and Jimmy Chang, who is a resident or fellow in genetics at Baylor. So the first thing they showed was that mTOR is inhibited by DFO. DFO is an iron chelator. And I don't think you can argue against this. It's completely gone, after 12 hours of treating with DFO, which is an iron chelator. So completely, the activity of mTOR is completely inhibited. And if you show this to people who are involved in mTOR research, they will say this doesn't make sense, because in response to growth factors, in response to amino acids, the response is within 45 minutes. It's within minutes. Here, we are seeing this effect happen after 12 hours. I'm going to explain later on why this happens after 12 hours. And this is not just a cell culture phenomenon that happens in response to DFO. If you treat mice, pregnant mothers with iron deficient diet, the pups become iron deficient. You can see these are normal, right? And these are anemic. You can see how anemic they are, these pups. And they also, their mTOR activity is reduced in their brain. So this does happen in nature. So what Jason did next was to figure out how low iron regulates mTOR. So he went through this pathway one by one, and he looked through pathways that are involved in the regulation of mTOR, and he ruled out each one of these pathways. And the one that he discovered to be involved in that mTOR regulation was amino acids. And this is the work again that was done by David Sabatini. He showed that leucine regulates cestrine. So when cestrine, when leucine is around, it binds to cestrine, and there's no effect. Basically, mTOR is on the lysosomes. But when leucine is not available, there are multiple, inhibitory effects, and as a result of that, mTOR is dislocated from life, and that's how it becomes inactivated. So what we did at first, we showed that in response to amino acid supplementation, if you have no iron, if you treat the cells with DFO, the activation of mTOR goes away. So here's what you see with mTOR activation: no band, you have a band, right? But if you have 18 hours of DFO, you have no band, you provide amino acids, there is no band. mTOR doesn't get activated if there is no iron in the environment, if you treat it. And also, mTOR on the lysosome is significantly reduced in response if you have DFO. And then the question is that, well, how does iron regulate cellular amino acid levels? And the first thing Jason did, he went and showed that leucine is the major amino acid that is reduced in response to iron deficiency. And he showed that the effect is that the levels of leucine uptake into the cell. That's what's defective. Leucine doesn't get into the cell. So if you treat the cells with leucine, you don't fix the problem of not getting mTOR activated. But if you give a form of leucine that can get into the cell, if you bypass this leucine uptake, then the mTOR gets activated. So there is a defect at the level of leucine uptake, and these are the proteins that are involved in leucine uptake. This is the list of them, and show that LATP and PAD1 are the ones that are affected by low iron. So this is what he has shown so far, that low iron inhibits LATP and PAD1 transcription, and that causes a reduction in leucine uptake, and leucine is needed for mTOR activity. So if you don't have leucine in the cell, mTOR doesn't get activated. So the question next is that how does low iron affect LATP and PAD1 transcription? And we said if you identify that, we will be able to identify this sensor we have been looking for. And for that, that since this was at the transcriptional level and most of the iron, available iron is in the nucleus, Jason decided to go after nuclear proteins and specifically focus on this histone demethylase. So for a long time, people didn't know how chromosomes open up, right? So chromosomes have to open up when there's transcription at the site where the where the histones go. And then people finally discovered that this protein modification of histones and DNA causes the opening of chromosomes, and that's how transcription occurs. So one of the factors that is involved in the opening and closing of chromosomes are histone demethylases, and these are called Jumanji C proteins or KDM proteins. And these proteins need iron. So they need alpha-ketoglutarate, they need iron, and they need oxygen. So one of these KDM proteins, KDM6, again, KDM1C, histone demethylases, are referring to the same family of proteins. One of these, while we were working to get our paper published, Bill Kaelin from Dana-Farber, just across the street, he published a paper in Science where he showed that KDM6A is involved, is the oxygen cis. So, but nobody had identified the alpha-ketoglutarate sensor or iron sensor for this. And Jason basically said one of these KDMs is involved in the iron sensor. So he did the histone mass spec, and the one he focused on was this mark on chromosomes, which is H3K9Me2. And I'm going to go through this quickly, but he showed that it does increase in response to iron deficiency, and it goes away when iron is supplemented into the cells. And then he showed that this mark is also increasing iron deficiency in the promoter of lactoferrin platform. So the question, so that's the mark that is changed. Histone mark, histone H3K9 dimethyl mark is increased. The next question is what's the Jumanji C or KDM protein that is responsible for that? In other words, what is it that is changing this histone modification to allow changes in the mTOR activity? I'm not going to get into details. He had to do a lot of CRISPR, use CRISPR to delete a lot of genes. He finally identified KDM3B to be the sensor for iron deficiency. And basically, he showed that the mTOR activity goes away in the control, but if you knock out KDM3B, the mTOR activity, the change in the inhibition of mTOR activity doesn't go away. And also the expression or the expression of lactoferrin platform, the effect goes away. So, and then he introduced the form of KDM3B that doesn't bind to iron, and he showed the effect that comes with normal, with normal KDM3B, that effect goes away if there is a mutation in iron binding of KDM3. And then finally, Jason, being a great scientist, he showed the same thing in these plants. In these, this is actually really fascinating. If you look at this, these are leaves of plants, right? And if you treat these plants with iron chelation, the plants stop growing completely. You see, there is no leaf production, and also their mTOR activity is significantly reduced, both in plants and in leaves. You showed that. So basically, what he has shown is that in iron deficiency, KDM3B is inhibited because it needs iron to be active. It's an iron binding protein. And as a result of that, H3K9 dimethyl mark is reduced, and the protein that is involved in the leucine transport into the cell is reduced. I didn't tell you, but Raptor, which is also a component of mTOR, is also reduced, and this is how iron deficiency leads to a reduction in mTOR activity, and that's how it causes a reduction in the anabolics. So you basically, if you have no iron in the environment, mTOR gets completely inhibited, right? And no matter how much, so the cell basically say, I don't care how much nutrient there is in the environment. If there's no iron, I'm not going to grow. Because this is at the transcriptional level. This is the only mechanism we know that mTOR is regulated at the transcriptional level. So if you don't have the proteins, it doesn't matter how much nutrition there is in the environment. The cells are not grow because you're not making the proteins that are critical for the mTOR activity. I want to thank my lab members, and specifically I want to thank Sam Weinberg. He said, He was an MD PhD student who I accepted to the program at Northwestern. Now he's on faculty. He's one of those people who finished medical school and graduate school, and he immediately became faculty. At the same time, he's doing his pathology residency. Really one of the brightest people I know, and he has been helping us tremendously over the past few years. And then finally, I mentioned this yesterday, to submit your papers to JCI. Feel free to ask me to handle your paper if you like. All right. You get that option actually. When you go to submit, it asks for which editor you want to handle your paper. You can always ask for me if you want. All right, thank you so much, and I will be happy to answer.
Great. Thank you so much. Sorry for all the technical difficulties. Anybody have any questions?
Thank you so much. That's a great talk. My question was about some of the efforts that have been done to direct iron, mostly iron chelators towards mitochondria. So if you think any of these are actually promising and are going to actually translate to humans?
Yeah, so deferriprone is a mitochondrial iron chelator, and that's being used extensively. And there is BPD also, but that's you have to do it IV. The deferriprone is oral. So yeah, some of this actually can get into the mitochondria. Of course, DFO cannot. DFO doesn't even get into the cell. It chelates iron in the outside the cell, so iron cannot get into the cell.
Everyone's listening online through my phone, so.
A political question. I guess we do see IV iron depletion quite a bit on the heart failure service.
Yes.
It seems like maybe there's some refinement that's needed in terms of who actually needs IV iron versus not. Are you sort of advocating for a PO iron trial first, or are you advocating for checking hepcidin levels to kind of figure out who actually is sort of truly iron deficient? How are you thinking about it?
Yes and yes, basically. So first of all, oral iron works in these patients. There is no evidence that oral iron doesn't work. There has been a push to do clinical studies in a way that would give positive results with IV iron. And IV iron is throughout evolution, 4 billion years, we have never had iron going directly into our bloodstream. This is the first time, right? And it does have side effects. Iron has side effects, and it can have an effect on the endothelial cells. It can cause oxidative stress. So the studies are not long enough to look at the side effects. And then in terms of what's the right criteria to study iron deficiency, you're right. Hepcidin would be great. If you can measure hepcidin, that would be the best way to diagnose patients with iron deficiency. The problem is that hepcidin is not easy to measure. So there's no, there's nothing on the clinical service to measure hepcidin. So a lot of these patients, if your ferritin is 100, you're probably not iron deficient. I mean, that's just too high. Or 300. Sometimes they go up to 300. So these patients, you're giving them IV iron, they probably don't need it, right? So that's why I think it's just a practice that is not based on science. It's just overused and it may have side effects and it's expensive.
The discussion of animal-based diets is that saturated starting to atherosclerotic disease. Do you think that animal sources of iron could also be contributing to atherosclerotic disease through some of the mechanisms you talked about today?
Yes. So let me answer your question in a different way. So we know that premenopausal women, they don't get disease, coronary disease as much as postmenopausal men. And we know it's not because of estrogen. We know it's not because of progesterone. So a lot of people think it's because of low iron in these patients. And there are studies, patients with thalassemia who don't get frequent blood transfusion. They also have low incidence of cardiovascular disease. So there's a lot of epidemiological studies. And there are studies in areas that are iron deficient. And they have lower incidence of cardiovascular disease. I told you, blood donors have low incidence of cardiovascular disease. it's very well established, lower hemoglobin. And this is well established that lower hemoglobin is associated with lower cardiovascular disease. So, I mean, these are all epidemiological studies. We should take them with a grain of salt, but they all point towards, low iron is actually good for the heart.
I was wondering, we use a lot of sirolimus, everolimus, in transplant.
What?
Yeah, sirolimus and inhibitors, and then with your data, are there cardiovascular effects or effects we should be thinking about that are related to iron metabolism with the mTOR inhibitor?
Right. So, we had actually an oncologist on Marina's case, and this does happen with sirolimus. There is a reduction in iron. They see that on the oncologist, they see iron deficiency with these drugs. So, whether or not it has an effect on the heart, we don't know. But we don't know if it's going to affect it.
I have a simple question. Does iron every other day or absorb better than every day? Because there was some paper 10 years ago, somebody in residency told me about it, or since then I've done it every other day. But is there any utility in that?
So if you take iron with vitamin C, it's probably absorbed better. If you take iron, with food, it may help with the ingestion of absorption. The bottom line is that if you're iron deficient, you're going to absorb. I mean, that's just something that has been shown over and over. But if you want not to have the side effects of, digestive tract side effects, and if you want better absorption, I think the best way to do it is with vitamin C. I think that's the best way to absorb it.
And is there a particular preparation you like? Sulfate?
So all of them are good. Again, I took one. It didn't because you just have to play with it, see which one works for you. But the new forms the iron is in the core of the shell, so they don't have any side effects in the digestive tract, and they're actually cheaper and they're not by prescription. So the FDA considers iron is a nutrient, so it doesn't need prescription. It can be over the counter. But IV iron requires prescription because it's not considered by the FDA to be a nutrient. So that's why it's over the counter. It's cheap and it's not, it's significantly less cost. You don't have FCM on formulary here, right? I don't think most hospitals in this country they don't. You have iron sucrose probably, and that's also cheaper than FCM. FCM is extremely expensive. Ferrous carboxymaltose.
We have one question online. When do you think the MET trial advocating for transfusion in AMI at lower hemoglobin? Or what do you think of that MET trial with transfusion thresholds in acute myocardial infarction?
Yeah, so it's not just that. We know erythropoietin causes more cardiovascular events. Blood transfusion, as far as I know, more if you have very low blood, yes, of course, you get blood transfusion, it may help. But blood transfusion, you're also loaded with a lot of iron. And most of them haven't shown that much benefit from what I understand. I may be wrong, but I think that's the answer I can give. But it's not just that. Erythropoietin has also been shown not to be beneficial. It causes more damage.
Thank you so much. Amazing. Thank you.